Dear ladies and gentlemen, my name is Elias-Leon Nolden, and my PhD thesis is about the implication of personalized medicine in maxillofacial surgery. I am a dentist as well as a fourth-year medical student. I'm from the Department of Maxillofacial Surgery and Oral Biology. My supervisors are Mihai Vasilko and Laszlo Köles, and my vision is that customization leads to optimization for better patient results. So my mission is also to provide better clinical decisions based on research. I have two ongoing specific goals. In my first specific goal, I'm comparing patient-specific implants and the stock system in patients with temporomandibular joint reconstruction, and I'm using here a systematic review and meta-analysis to achieve this goal. TMJ disorders are very common in our population. In fact, almost every third child and 11% of all children and every third adult is affected by it, and untreated it will result into failure of the joint, which will come with unstoppable pain, problems with diet, mastication, speech, and social interaction. And we already know that in just 6 years, the necessary amount of TMJ operations will be increased by 60%, which will be just 900 operations per year in the USA. So what we can do, we have two options. We can use the traditional stock system, which comes in 3 standard sizes. However, a common limitation for that is also its jaw mobility. On the other hand, there's a new kit in town, which is the fully customized implant for our unique patient's anatomy. But also there, as stated in the current clinical guideline, the total number of global cases is still insufficient, so it cannot be any stable conclusion drawn yet for the PSI. That's why our aim is now to investigate if the PSI or the the stock system is superior. We were investigating in patients under TMJ replacement, and we are comparing the PSI with the stock system. Our outcomes of interest were the maximal interincisal opening measured in millimeters, as well as the pain and diet measured by the visual analog scale. Our hypothesis is that the PSI is superior than the stock system. We did our search on the 5th November 2023, and after full text selection, we were left with 45 eligible articles, including 35 one-arm and 10 two-arm studies. Our first outcome of interest is the maximal mouth opening. It is of crucial importance for our patients that they can maintain a necessary jaw mobility in order to keep oral hygiene, have no interference with speech or diet. It is measured by the interincisal distance in millimeter, and as stated in the guideline, a mouth opening between 30 and 40 millimeters after surgery can be considered as successful. So that's why each millimeter toward this direction really counts and will improve our patients' postoperative quality of life. We could include 45 different studies, mainly cohort studies with a high heterogeneity due to lack of pathology grading in the studies. And our goal was here to subgroup them based on the follow-up time as a very possible narrow follow-up time in the first year to directly see potential difference between custom and stock. On the left side now you can see our results. The effect size is the change from preoperative due to the different follow-up times, and on the right side you see the difference between the two systems. It is mainly in all subgroups favoring custom. However, as none of these subgroups could reach a mathematical significance, and as the difference between the two implants is so minor, we consider these as not clinically relevant. This figure now illustrates you the absolute numbers of the mouth opening, meaning both systems work very great. Looking at the change of the mouth opening, we see that there might be the custom might be superior in the first 1.5 years. That's why we also wanted to analyze our two-arm articles separately, and in a short-term follow-up time until 3 months, we could see that you could expect a 4 millimeter larger opening with the PSI. The same for the 3 to 6 months follow-up time, where you can expect a 5 millimeter larger mouth opening choosing the PSI. In the long-term follow-up above 1 year, with 6 millimeters favoring the PSI again, we could also reach here a mathematical significant difference now, so that's why we consider this result as clinically relevant. Regarding our second outcome of interest, the pain, the orofacial pain is measured by the visual analog scale, with 0 indicating no pain, while 10 indicates the worst pain possible. Here also the goal is, of course, to have a pain-free time after surgery to ensure good postoperative rehabilitation. Here we could only include 36 different studies, again with a high heterogeneity due to lack of pathology grading and lack of indications. Here we also wanted to subgroup them based on a possible narrow follow-up times to see potential differences. On the left side, you can see those results. Again, this is the change from preoperative. On the right side, you see the difference. Here we have quite contradicting results. First the stock, then the custom. This can be explained due to the heterogeneity of our data. And as none of these reach the mathematical significance, we consider these as also not clinically relevant. This figure now illustrates you the pain change, and also here in both systems, pain can be successfully decreased. We could also analyze our 2 articles based on that outcome and can see that it's slightly favoring the PSI with 1 centimeter more change, more decrease on the visual analog scale. Also for the long-term follow-up above 3 months, slightly favoring the PSI. However, we consider these as not clinically relevant. Our last outcome of interest is the diet. Diet is obviously indirectly related to pain and mouth opening as well. However, it can be measured separately with the help of the visual analog scale again, with 0 indicating no restrictions in food, while 10 means that patients only can take liquid food. Here, the goal is again to have possibly no restrictions in diet to ensure good postoperative quality of life. We could only include here 15 studies with a high heterogeneity and could subgroup them in a short and a long-term follow-up. Here again, first is favoring the custom, then the stock. This might be also explained due to the heterogeneity of our data. And as none of these 2 subgroups could reach a mathematical significance, meaning that there is also no clinical relevance in that results either. In summary, customized TMJ implants enhance mouth opening but do not significantly affect pain relief or dietary compared to the stock system. And our implication for practice will be that customized should be for those patients who have restricted jaw movements, while the stock implants is a more cost-effective alternative for patients with pain management. And both systems accommodate dietary needs effectively. The implication for research that further research should focus on developing and comparing those implants to address these limitations such as pain and diet. The strength of our study is that our subgroup analysis yields the more precise results and has the most narrow follow-up times. As well, we have the most comprehensive study to date. Our limitations is clearly the high heterogeneity due to no pathology grading, as well as pain and diet can only be assessed subjectively. We finished our manuscript and are now soon starting with the internal review, and our target journal is the Journal of Craniomaxillofacial Surgery. Regarding my second project, we are here also comparing patient-specific implants and non-customized implants in patients with cranioplasty. Cranioplasty protects our patients from cerebral seizures. It can relieve headaches, increase brain blood flow, and improve the brain energy metabolism. That's why it's also considered as a standard procedure in neuro and maxillofacial surgery. However, it is associated with extremely high complication rates compared to other routine neurosurgeries. Here, again, we have the possibility to choose between 2 ways. We could go for the non-customized implant, but as you can see on the left picture, it often shows imprecise fitting with low aesthetic satisfactory. So our aim is here also to investigate if the custom or the pre-curved implant lead to better patient results. That's why our clinical question will be, does cranioplasty with custom-made or pre-curved implant lead to better clinical performance and long-term success? And our outcomes of interest is the clinical performance measured by the cranial index of symmetry, as well as the time. Safety is measured by the postoperative incidence of postoperative complications, and the aesthetic by the visual analog scale. Our hypothesis is that the PSI is here also superior than the non-customized implant. And our implication will be a long-term implant survival, less secondary operations due to less complications and decreasing anesthesia exposure for our patients. We considered our topic as feasible and soon starting with the Prospero registration. So in summary, both of my projects are investigating in personalized medicine and maxillofacial surgery. And I would like to end my presentation with my favorite quote from Eugen Reut: "A human often feels quite transformed when treated humanly and warmly adored." Thank you very much.
Thank you very much. Congratulations on your choice of topic. One comment I would like to give you is I couldn't see surgical time, surgical duration when you assess your outcome measures. And we all know that whenever you use custom implants, custom devices, it may shorten surgical time. Is there information in the literature regarding that?
Thank you for your comment. Definitely there is information. We couldn't conduct it as a meta-analysis or could include it in our meta-analysis due to, as you already said, the custom implant doesn't need any alternation of the patient's anatomy or of the implant themselves, while the stock often needs both. So the custom is in fact faster. However, it's also influenced by the operator, how experienced the operator is. This might be actually the most influencing variable. And as it is also the articles where surgery time was given, they didn't explain any further when was surgery start and end. Is it when the anesthesia comes in the room and starts to along the patient, or is it when the surgeon does the first cut, basically? So that's why we couldn't include it, but it will be part of our discussion.
Thank you very much, because shorter surgery is not just an advantage for the surgeon, so that the surgeon can treat more patients, but it's also beneficial for the patient, because the shorter the general anesthesia is, the lower the stress on the cardiovascular system. Thank you very much.
Congratulations for your presentation. I'm curious about that. This is a very interesting topic, and Semmelweis maxillofacial is a strong center for rehabilitations like this. However, translational medicine aims to transform the meta-analysis and systematic review ideas into clinical trials. Do you have any idea how you can transform your knowledge and your interest into a clinical field? And do you see any ideas in the future where you would like to be busy with, and which specific part of this rehabilitation are you most interested in?
Well, for the first part of your question, here at Semmelweis, I think the biggest center for TMJ replacements in Eastern Europe is in Slovakia, but they do obviously also TMJ replacements here in Budapest. For the implication of my study, it very depends also on the access of the university, as it is also a big money aspect, those implants to print, and also takes more time. So I would definitely say that it can be implicated, the customized implants, as especially surgeons tend to use newer technologies in surgeries which come closer to physiological demands, what would be the case with the customized implant. However, I think...
because TMG surgeries are, I think, we choose more conservative ways when we treat TMGs, if it's possible. But also, there is a lot of orthodontic patients who are having huge rehabilitation surgeries in Maria Street, for example. So I really suggest you to probably, if you are getting involved there, it might be very interesting clinical trials in the future, and this is the aim of this program. So I'm cheering for you. Thank you.
Thank you very much for that suggestion.
Congratulations on your presentation. I have one question regarding the first topic of the PSI. You didn't specifically talk about if there was any operational risk or surgical risk that you want to talk, like if you've read in the research, if they have more, for instance, risk, or is it more safer to do than the stock system?
Thank you very much for that question. As the stock implant often gets altered during the operation, meaning it has to be adjusted to the patient's anatomy, or the patient's anatomy has to be adjusted to the implant. The amount of surgical risk, the incidence rise. Especially we see that when we change surfaces on the implant, it can weaken the material, which could lead to potential implant failure later during the postoperative rehabilitation, as well as any changes in the patient's anatomy might also increase the risk for any surgical risks, such as the most common is the damage of the inferior alveolar nerve. So that's something we could definitely see more than in the custom.
Thank you so much.
Thank you.